Just a broad overview of the different lumbar interbody fusions. Sorry, the PowerPoint crashed.
Just crashing?
Yeah. These are my disclosures. I think the only relevance is that you'll see some of the implants here, but otherwise trying to be vendor agnostic. So as a brief outline, we'll introduce each technique. I know we have a lot of distinguished speakers talking individually about the specific technique, so we're trying not to steal anyone's thunder here. But we'll talk about minimally invasive TLIF, endoscopic TLIF, the different lateral lumbar interbody fusions, trans-Psoas and the anti-Psoas approaches, and we'll also talk about ALIF. We'll provide a few case examples for each approach, and then we'll briefly discuss some pros and cons. So what is kind of the unifying theme of minimally invasive lumbar surgery? So, when I think about it, the common thread is that we're talking about surgery of the disc space. So that's where all the different lifts come into. And so with that, we have different anatomic corridors to access the intervertebral disc space. And then you have a few core things that you want to achieve when you do this. You want to be able to remove adequate disc material to allow for a good interbody arthrodesis. You want to be able to place an intervertebral implant to do a disc space reconstruction, and then hopefully restore as much segmental lordosis as you can. And then the final thing is you want to disrupt the surrounding tissue as little as possible, because that's really the name of the game for minimally invasive surgery, right? A lot of you probably recognize this schematic. So when thinking about where the vertebral column and the disc is, it's centered in the middle of the body cavity. So basically, with each approach is just what direction are you headed to the spine from? So first talking about the oh man. Crashed again. So first talking about the TLIF. What's the T in the TLIF? Is the transforaminal, right? Sorry about that. And so this is a paper by Andrew Fanous, Lou Tumialan, and Mike Wang. So talking about Kamin's triangle. So if anyone's gone to an MIS TLIF course, you hear about Kamin's triangle. The interesting thing is that the way it's described classically in minimally invasive techniques is not entirely correct or true to Dr. Kamin's writings. So typically what we're taught is that the medial border is going to be either the traversing nerve root or the thecal sac. The lateral border will be your exiting nerve root, and your inferior border will be the superior end plate. But in Kamin's original writings, he talked about the superior articular process as being kind of the roof of the triangle. So it's not really a triangle when you have four pieces to it, but again, that's what he originally described. Now, so the authors in this paper, interestingly, they observed that part of the reason why the SAP gets omitted is that usually it's removed when you're doing a TLIF, and so that's not really becomes a consideration. So the paper is pretty interesting. They talk about different variations of how you're approaching this space, and this is basically your access point to the disc. So with an endoscopic TLIF, there's different ways to do this, and Christoph will talk in more detail, but you can or you cannot have a limited removal of the SAP and maybe a limited removal of the inferior articulating process as well. Your trajectory here is going to be toward the center of the disc space, and you have about 9 millimeters of access. And then if you're going to be putting some sort of interbody implant, probably you're going to need something with an expandable capability. And then when you look at, I guess we can call it the traditional MIS TLIF, you have a much more extended bony removal. So here you can see, in addition to the SAP and IAP, the lamina and pars have also been removed as well. So this allows you the capability to decompress the spinal canal, and that's kind of traditionally how the TLIF was taught. Nowadays, now that more people are believing in indirect decompression and things like that, there's variations where you leave the lamina, you leave the pars intact. Personally, when I feel that a direct decompression is not necessary anymore, I'll leave these structures intact to protect the things like the DRG, as well as the traversing root to minimize the risk of a neurological injury or durotomy. So here's just a case example from my practice. So there's a patient that one of my partners had operated on previously did traditional open laminectomy. Patient developed spondylolisthesis and disc collapse from L4 to S1. So we did a minimally invasive TLIF to kind of reduce the spondylolisthesis and reconstruct the space. So for a lot of MIS surgeons, this is your workhorse operation. So what are your advantages? So alluding to a lot of everyone's training, we're trained to do approach the spine posteriorly primarily. So this is probably the most familiar anatomy for any sort of minimally invasive approach. In addition, it allows for direct decompression of the spinal canal if it's necessary. And then finally, you can achieve posterior fixation from the same approach. So this is what I like to call the original single position surgery. You're there, you're prone, you're putting your cage, you put your screws in. What are the disadvantages? So you do have a somewhat limited access to the disc space, and you're constrained by the nerve roots. And this can be especially difficult if you have a severe fractional curve that you're approaching from. In addition, you've got a limited size of the intervertebral device that you have. And then, again, there's a risk of the neural structure. So durotomy, injury to the dorsal root ganglion, and then also post-op radiculitis, which I think it's something that happens to a lot of people, but it's not something that gets talked about a whole lot. So then talking about moving on to the lateral lumbar interbody fusion, so here approaching from the side. So again, this has, as the technique has evolved, it's developed a few variations. So thematically, what kind of links these approaches together? So one is the retroperitoneal approach to access the intervertebral disc from a lateral trajectory. Secondly, we're going to be releasing the annulus laterally on both sides of the disc. So this allows for quite a bit of capability to correct any sort of coronal curvature. In general, you're going to position your interbody device to span the entire vertebral end plate from left to right. And this can be done standalone or with posterior supplemental fixation. So I think the original technique, most people will agree on, is the trans-psoas technique, where, again, it's retroperitoneal, you're going through the psoas, and with that, you have to consider the lumbar plexus anatomy. And as such, you need some sort of intraoperative neuromonitoring to make sure that you're doing this in a safe fashion. A slight evolution to this is the anti-psoas approaches, or OLIF, or ATP, anterior to the psoas. So here the disc is actually accessed from a window anterior to the psoas muscle and lateral to the aorta. This does not require neuromonitoring because you're not directly distracting the psoas or manipulating it as much. One caveat is you do have to approach the patient from approach the disc from the patient's left side, so that can have some specific caveats. So here's just a diagram, what our kind of traditional trans-psoas approach. You have a retractor, some sort of bladed retractor that is docked into the psoas, and then you're accessing the disc space directly from a lateral trajectory. So here's another real-world example. This was a lady, she's a paramedic, had multiple disc surgeries, multiple discectomies. Had recurrent radicular symptoms just from foraminal disc collapse. So this was a lady we did a 2-level lateral with, and with posterior fixation. So you can see the type of reconstruction you can get with restoring disc height. If you'll notice on the pre-op film, she's got a little bit of a fractional curve that's developing as well. So that's corrected as in the post-op AP. So as far as for the trans-psoas pros and cons, advantages are it allows you to do a larger interbody device, and there's a lot of different options here. You can have different materials, PEEK, titanium, porous PEEK, 3D printed. You can do expandable cages, things like that. There's no risk of durotomy. I mean, anything can happen, but really if you're paying attention to what you're doing, this is basically never going to happen. And it's also useful for redo operations because, again, since most of the approaches are posteriorly, when you're approaching laterally on a redo operation, you're going through virgin territory. As far as for disadvantages, so the anatomy can be somewhat unfamiliar. Lateral itself has become very much part of the vernacular for MIS surgeons, but when you look at a lot of general neurosurgeons and orthopedic spine surgeons, this can still be a little bit daunting. And then your access to the disc space is limited by the lumbar plexus anatomy, and as was been previously mentioned, this is especially pertinent at L4-5. And then finally, neuromonitoring is necessary. A lot of times we don't think about this, but it's it is an additional cost to the hospital. So you have to think about what's your value gained by doing that in terms of cost. So getting into the anti-Psoas lateral fusion, so there's a few brand names associated with this, and then I think initially when this was taught, this was recommended to be performed in conjunction with a vascular surgeon. So essentially here, you're still approaching from a retroperitoneal approach, but your docking point is anterior to the psoas. Maybe you dissect the psoas off the lateral disc space a little bit, but you're approaching from more of an oblique angle. You have to do this from the left because you don't really have that window on the right side with the vena cava. But an advantage is you don't need to EMG because you're not really doing a whole lot to the psoas. Maybe you're pushing on it when you're getting your instruments down, but that's very transient. And then in the end, your interbody spacer ideally should end up in the same orientation as a standard transpsoas lateral. So here on the schematic, you can get an idea of how this is done. So you have your retractor that's docked in kind of an oblique position, you're doing your discectomy, and then when you're doing your implants and your trials, you're gonna make like a turn where you're shifting forward so that you have the proper orientation of your implant. So, here's an example, some Interop Fluoro. So from an AP view, this looks like your standard lateral, right? We've got your retractor blades, you can see the cage is in place. But then when you look at the lateral fluoro, you can see that the retractor is off at an angle. And then this is ideally, you want to still be in the same orientation as your traditional, like your transpsoas lateral. So slight nuances there. So advantages here, this really opens up the instances where you can address L4-5 pathology from a lateral approach. Couple instances we've talked about or it's been mentioned, high iliac crest. The crest becomes a non-issue when you do these types of procedures. And then for the anatomy where the psoas is pulled a little bit anteriorly, that pulls the plexus more into your docking space for a transpsoas lateral, you have a little bit more wiggle room because you can, you might still have a good window to dock obliquely, and then you can safely do this procedure from an anti-psoas approach. Other advantages are just you avoid direct retraction of the psoas muscle, so there's really no risk of a lumbar plexus injury. Disadvantages, you have to approach from the patient's left side, which for the most part isn't always a big deal, but the anatomy can be even more unfamiliar because instead of approaching directly orthogonal to the spine, you're approaching a little bit more of an angle. So there's something where image guidance and robotics can be helpful to help orient. And then finally, we'll talk about the anterior lumbar interbody fusion. So thinking about the ALIFs, ideally, I think anatomically, this is ideal for accessing the L5-S1 disc space. It allows you to place a large cage with a pretty sizable graft window, and this allows you for some hyperlordotic cages that can be placed. And looking at your global sagittal balance or lordosis, most of your lordosis is in the most distal lumbar levels. So at L5-S1, as much lordosis as you can get is ideal. You can access L4-5 in the more proximal levels, but a lot of this is dependent on a combination of the patient's anatomy as well as the comfort of your access surgeon. Traditionally, this was performed supine, but nowadays you can approach this in a similar approach from a lateral positioning, either through OLIF or lateral ALIF, where you're still taking advantage of the retroperitoneal corridor to approach the spine. And then in cases where you have to do a corpectomy or you have to do a lot of retraction of the iliac vessels, might be necessary to monitor pulse oximetry for the lower extremities while you're doing your surgery. Okay, we do have one more crash. Apologize. I guess next time I should use the Mac software for this instead, huh? Okay, so here's a diagram just showing the anatomy from the anterior approach. So again, so we've got the vertebral bodies labeled. So you can see naturally you're taking advantage of the bifurcation of the iliacs above the L5-S1 disc space. So you have a nice corridor to access this. There's a lot of different variations of where the vessels will sit more proximally, but you can see for things like L4-5, 3-4, and 2-3 are possible. It just depends on the anatomy and your approach surgeon. So, and then here's another real world example. So This was a younger gentleman. I think he was a tradesman of some sort. He had developed back pain and saw another surgeon in the area who decided to put 2 interspinous devices. So I'm not sure if it projects well, but this patient actually has a pars defect at L5, and he's got a slight is an isthmic spondylolisthesis that's mobile. And I don't have the CT, but you can see it pretty clearly. So I think the diagnosis here was missed. The patient had back pain, but also had the, kind of that classic L5 radicular symptoms that you get with people with the L5 isthmic spondy. So here we did an ALIF, and then I tend to back these up just because you don't have any posterior elements that are intact with a pars defect. So, and this patient did pretty well with that. So, I think for me, this is kind of your ideal sweet spot for an ALIF type procedure. And again, advantage and disadvantages. So with the ALIF, you can put a large interbody device. I like to call this the original ALL release procedure because that's what you're taking out when you're approaching the disc space. So this gives you the flexibility to put some hyperlordotic cages if you want to use it in combination for any sort of deformity correction. And there's really no risk of durotomy here as well because personally I don't do anything with the posterior annulus when I do an ALIF, so no risks there. As far as for disadvantages, now not everyone needs an access surgeon to do this, but typically a lot of people do, so that's a limitation. There's risk of great vessel injury as well because that's in the neighborhood. And then also for men, there's risk of retrograde ejaculation or erectile dysfunction, which is an important consideration, especially if you have younger patients who still want to have families. This can be, although it's a pretty rare complication, if it does happen, it could be potentially pretty catastrophic. So in summary, there's a multitude of options to perform minimally invasive lumbar interbody fusion surgery. Certain approaches lend themselves to specific scenarios, and I think individually as surgeons, you have to determine what works best in your own hands. So when your patient comes to you, you see the pathology. You think about what works in your hands. You think about things like workflow and trying to lower your stress level and things like that. And really, as you get more experience, it's all about complication avoidance. So you want to kind of narrow that window of error as much as you can from a safety standpoint. So I think that's everyone's a little bit different in terms of what they feel comfortable with. But I think if you approach it from this framework, it'll keep you out of trouble. So thank you. So any questions?
That was an awesome summary. It really it shows that you're standing over that, which is really great to see. My question was, what is your, framework of thinking if you have to, instrument somebody from, let's say, from L2 to sacrum, and for anterior interbody, because L5S1 is always challenging, right? No matter what you do, is it a TLIF? It's a little bit different. It's like, X-lifts, also E-lifts are not possible. They're extreme laterals. So what's your, kind of go-to framework when you plan that?
I think it's all very patient specific. So I think with doing, one of the things with doing the anterior ALIF and doing the anti-Psoas approach is you can do an ALIF from a lateral position and you can do multiple. You can do traditional trans-Psoas or you can do anti-Psoas approaches for the more proximal levels. And a lot of times it depends on how much lordosis the patient needs. So if it's more, spondylolisthesis, disc collapse, that type of thing, I might just do multi-level mini-open TLIFs and supplement. So it really all kind of depends. I agree. I'm not a huge fan of doing TLIF at L5S1. Even with a lot of the different types of expandable cage technology, it's still, leaves a little bit to be desired in terms of your reconstruction. So I think an ALIF is really ideal in those types of circumstances if you need the segmental lordosis.
Richard, can I ask a question?
Sure.
I think it's a great talk, and I think it covers things up well, but I've had some great experience with right-sided OLIF. So I just think, and I think it should be taught there. I think it should be taught on the left side. But on the right side, it's just a matter of respecting the vena cava. And so you can retract the psoas, who's down right between the interval, pull the psoas over, and you're doing the same thing. You just got to be careful with the vena cava. And the best use of a bilateral OLIF is in an infectious discitis. So like an L3-4 infection, you go in from the right side with an OLIF or transmuscular, gut out the infection, put a reversible implant in that's going to come out eventually on the left side, fill it with antibiotics. So you kill the infection, you maintain your alignment, and then go do a traditional OLIF or transmuscular on the left side, pull that implant out, and put in a nice implant with a graft. So just as an idea that all these things are possible, but you're right, it's a left-sided approach, but it's got a right-sided capability as long as there's an appreciation of the vena cava. That's the only point I'll make. I think everything else I agree with.
Yeah, no, that's an excellent point. I mean, I'd like to learn right-sided OLIF from you then, because I typically, not because of any other good reason, I do all my trans-Psoas laterals from the right, and it's just because of the way the room's set up in our OR is, where if I have them on the right side up, then the head is towards anesthesia, and you want your fluoro kind of away from you when you're doing these laterals. So if I did left side up, it's a little bit more. You basically have to flip the table or something. So yeah.
What is a reversible implant you're talking about? Is there? I don't know if I've ever seen that. So you put the implant in, it has some structural support capability. It's hollow, so you leave antibiotic beads or whatever in there, and it can be retrieved fairly easily from the other side. Is that it? So it has no like retention grooves or anything like that?
Yeah, it's. We're trying to stay away from brand things, but this was another box. So it had that little screw you can screw into the implant. So if you put it in reverse, where the screw is facing the left side, you can just impact it and fill it with antibiotics, and then when you come back to do your OLIF, you just screw it in and just take it right out the left side. So it's in reverse. It's just put in reverse from the right side. It's actually in its normal position if it was a left side OLIF, but you're putting it in from the right side, so you.
I think I see what you mean.
Yeah.
But it's really a wonderful technique for infection. It's the best thing I've ever done. And I had a case last week that had a transmuscular approach, and the problem was the entire psoas atrophied. And there was a huge plexus injury. Someone just didn't, trans-psoas is a good operation done by the right people, but when it's done wrong, it really goes bad. This patient was in terrible pain. He could not go back to the left side. So we went back to the right side and did a right side OLIF and retrieved the cage and avoided that plexus and the psoas.
Vic, what are you? There are people who are either trans-Psoas fans or OLIF or anti-Psoas fans. Which side are you on?
Well, I think for me, 3-4 more proximal trans-Psoas makes the most sense, and I think for 4-5 the OLIF, I think it opens up the possibilities because my go-to for L4-5 has always been MI's TLIF, but there's certain instances where it's not. If you could avoid doing a TLIF, it'd be nice, especially where someone has like a really bad isthmic spondylolisthesis where the disc space is really collapsed and the back of the an L5 body is riding up. You can just imagine trying to get like a paddle shaver posteriorly is pretty hard. So, and then unfortunately, a lot of those people have pretty unfavorable psoas anatomy for a trans-psoas approach. So I think in those instances, you could always do an ALIF, but my access surgeon can't get me there. So you're kind of on your own. So an OLIF in that or an anti-psoas approach in that instance, I think can make your life a little bit easier. Osama.
So I wanted to ask, what are your measures to avoid a plexus injury? We've heard that multiple times today, how devastating they are. So what are your ways of preventing it when you're doing a trans-Psoas approach?
Right. Well, I think a lot of it is just looking at the anatomy ahead of time. And this is, I've learned this from listening to talks from like Juan Uribe, Adam Cantor, because they've done Dr. Pimenta, they've done tons of laterals. So I think planning ahead, we're, especially as neurosurgeons, we're used to just looking at a very small subset of the anatomy. But when you start doing more lateral surgery, you start looking at all the other structures surrounding the spine. And in particular, you start looking at the psoas and you start trying to identify where the lumbar plexus is sitting. And so it's just looking at your films ahead of time, trying to identify that plexus and see where that is relative to your ideal docking zone for your disc space. And if it looks like the plexus is going to be in the way, or even if there's a question of it, then I just wouldn't go there. Other things you do intraoperatively. You do intraoperative monitoring. Even if you get, say you're 10 milliamps, you get nothing around it. I like to have the technologist ramp up the amperage just to make sure everything's working. Because you want to have a positive control. You don't just put your dilator, start stimming, everything's clear. It's like, oh, everything's good. You want to make sure it's actually working. Other things, just reducing your retractor time. That's also something that people talk about, staying 20 minutes or less. So, like was alluded to earlier, it's a team approach in the OR. So you want everyone to know, you're on the clock once the retractor's down, the shim's down. So have everything ready. People shouldn't be like having side conversations. Everyone should be kind of focused on, getting the implant in as quickly as you can, and then, then you can relax.
Hey, Nick, one question regarding the, when you get in the psoas, do you do like they used to call it direct look, or like do you dissect the psoas and the psoas must pass your application, or did you revert to kind of like just?
Well, that was kind of what I was trained as a fellow, but then, talking to some other people, they just don't do it, and they don't, they feel like it's not necessary. So basically what I'll do, I'll directly visualize to the point where you open the transverse abdominis. Then I put the dilator under fluoro, and then, you're really depending on your EMG at that point. And so I don't really bother dissecting the psoas or anything like that. So sometimes there's a few things where, if you're getting a positive return at a lower current than you're expecting, one of the things you can do is like lift your dilator up, work it anteriorly and kind of pull the psoas back. So that's a trick I've learned from other folks as well. So I think like anything else, you just have to do enough of them. You have to have a few cases where you struggle, work your way through it, and kind of you learn all these different pearls to kind of get yourself out of trouble and put yourself in an area where you can be successful with the surgery.
Cool.
Thanks.
Great.